This week's episode of EHA Unplugged highlights a discussion on the management of high-risk MDS. For more information on the treatment and management of MDS, check out the newly published MDS treatment algorithm on the EHA campus. The MDS algorithm and associated vodcasts were planned and conceptualized by EHA and funded with an unrestricted grant from Novartis.
Welcome to Valeria and Katharina. Today we're going to talk about high-risk MDS and how we actually treat high-risk MDS and how we define high-risk MDS. And I'd just like to ask you to introduce yourself.
Okay, my name is Valeria Santini. I work at the University of Florence. I'm the chair of the MDS unit, and I work in the hematology department.
My name is Katharina Götze. I'm at the Technical University of Munich and head of leukemia service there.
So we've been looking forward to this. So there's a lot of new things going on with respect to how we actually diagnose high-risk MDS and what we call high-risk MDS nowadays. So would you please comment on what your thoughts are about this?
There have been very recently two publications in June 2022 that are setting the point for a new classification of MDS. Unfortunately, there are a little bit some differences among the two classifications. One is the WHO classification and the other one is the ICC. While there are these discrepancies, we think that both of the classification just target some critical points in the classification of MDS. That is the fact that in fact, MDS and AML are two different diseases, but especially talking about high-risk MDS, the WHO 2022 indicates still the difference in increased blast 1 with blast from 5 to 9% in the bone marrow, and increased blast 2 from 10 to 19. Whereas in the ICC, the high risk, let's say, MDS considered as the ones with blast in the bone marrow are all put together. So if you have more than 5% blast, this is considered an MDS. And then if you have higher than 10%, you are already an MDS AML. And this can be confusing for many reasons, for patients mainly, because they can get two different diagnoses, and also for reimbursement, because some drugs are directed to MDS and some other to AML and registered and approved for that. So this is something we should really correct some way. And the other problem could be also the fact that there are some MDS, and we will discuss it largely, that are characterized by mutation in TP53. And while in one classification, the difference between biallelic and monoallelic TP53 is stressed, in the other is only linked to the blast percentage, yes or no. So
which one is which one, please, of these two?
So in the WHO, there is a difference in biallelic and monoallelic. And I think that this is something that it makes a difference. But we all agree, and all the two classifications do indicate the same, that TP53 MDS are really a different kind of disease. And category, they should be set apart. Yeah. They are indeed a category apart of MDS.
Now, so you say that there are some problems with respect to reimbursement and understanding from the patients and so. Are there any good things about mixing these things together? AML and MDS.
I think that grouping the classes according to their genetic subtypes actually does make sense, because we know that TP53 multi-hit MDS and TP53 multi-hit AML have the same survival curves. So they're actually completely the same. There's no difference in the overall survival curves in the Kaplan-Meier. So I think that putting those two together and treating them the same way absolutely makes sense. And for the ICC, having MDS/AML opens the trials for patients with MDS into the AML trials, which I think is one of the reasons that was grouped together.
Yeah.
There are pros and cons, and I think that we should come to a merging of the two classification, because we can actually point out very good indication and characterization of MDS in both the classifications. There is a little bit
confusing. I agree. I also, and when you teach also MDS nowadays, it's very complicated because you all the time have to say this is two different things, right? So actually, I think it is confusing for everybody. But what do we do for now? What about now? I think we have already in some of these sessions talked a bit about P53 because this is a major issue, right? But what about all the other mutations? Would they help us in sort of the classification?
I do think it's becoming increasingly important to classify MDS in genetic subtypes. And we know that, for instance, for SF3B1, we have a predictor for response to luspatercept, so that absolutely makes sense. But we also know that low-risk MDS was SF3B1. As soon as there's a second or third mutation in del5q and then maybe something else, RUNX or ASXL1, the prognosis is a lot worse all of a sudden. So this is information that we need to have on our SF3B1 mutated patients. Do they have additional mutations? And then for IDH mutations, which are about 7% of all MDSs, we hope that we will be able to target those with IDH inhibitors together with HMA, and there's preliminary phase 1 data on this and the phase 2 data from MD Anderson that's looking quite good. So also for refractory and relapsed MDS after HMA, it might be good to target them with IDH inhibitors. So yes, I think it's important to have these classes because they do inform therapy.
Yeah, this is particularly true for lower risk MDS. But as Katharina mentioned, IDH1 and IDH2 may be very important for higher risk MDS as well. And we already know that the number of mutations is critical for outcome. So not only the type of mutation, but also the number of mutational events in an MDS. And for higher risk MDS, of course, the combination of TP53 and complex karyotype can be really determinant for prognosis. So now we have a new classification that is upgrading mainly what was considered with IPSS-R as lower or intermediate risk to higher risk, just on the basis of the type and number of mutation. So DNA mutation are becoming increasingly important.
And do you think we can reach a point where we actually don't need to count the bone marrow blasts anymore?
Yeah, that's a difficult question, Kirsten. I actually do think that blasts are important in the sense is when you're thinking of treating a patient with HMA and perhaps they have no blasts at all, but they have an IPSSM that's higher because of their mutations, I would have a difficulty giving a patient HMA with no blasts at all. Yeah. Because I wouldn't be sure of the benefit that the patient is getting. And as the patient's age, and maybe they're 85, I'm not sure that they would actually derive a benefit from the HMA at that point, and maybe just, do best supportive care and leave them alone. That's also always an option.
Yeah, absolutely.
Yeah, absolutely, yeah.
Yeah, and in Europe, we are not using HMA in lower risk MDS. We use them only in higher risk MDS. So even if you have a non-blastic marrow and mutation, as Katharina said, there is some reluctancy in using HMAs because of
myelosuppression. Yeah.
Exactly.
Yeah. And also, do you see good results in that situation? Do you know about that? I mean, they do it in the States, right? But
well, you can alleviate the anemia quite well. But if you have neutropenia, I don't really see any effect. So I think for anemia, after maybe failure of EPO, failure of luspatercept, and all these things, it could be useful. But if there are no blasts in the bone marrow, I'd be very hesitant.
Yeah. It can be alleviated. But again, it's something we should use with real care and attention.
Yeah.
It's kind of the issue that this is all we have for high-risk MDS, in spite of allogeneic transplant, which of course we can offer to some of the younger patients. And then we have HMA. So it's kind of like, we give HMA to everyone because it's it's the only thing that we have for high risk MDS, but I think we need to be a little more discerning and really choose the patients well that will benefit.
Yeah.
Yeah. Yeah.
Regarding
so do you have a limit for when you're using HMAs, or is it individual from each patient?
Not really, depends on the conditions of
very
health conditions of the patient. I treated patients who were 90 and above but had a very fit condition, and others who were 80 but were not really eligible, not even for HMAs.
No, it's physiological age,
absolutely,
really.
You have to evaluate your patient with comorbidities, general, also geriatric assessment somehow to see whether compliance and
coming in for 7
and also
days
caregivers and everything. So in this sense, maybe oral HMA could help us. Because then the management of elderly patients could be easier. Nevertheless, even if oral, these are myelotoxic, myelosuppressive, let's say, drugs. So even when we will have the oral formulation, it would be extremely, extremely delicate to manage an elderly MDS, higher risk MDS patient.
And we don't have this in most countries. We don't have the same setup that I know that you have in Denmark, where you can do the outpatient nursing going around to the homes and giving HMA. And we don't have that setup in Germany. So the patient has to come in all the time and get their blood values checked. And so that can be quite.
Yeah, that's kind of tough, I think. Yeah, I think a lot of patients actually like being treated at home. I think that's one thing that we've been doing a lot here. Yeah, it's true.
Yeah, they are relieved.
Yeah.
In this sense.
And it makes a lot of difference actually for the quality of life.
Yeah.
And are we good enough to measure quality of life in this patient category? Because I think this is probably key, right?
A very pertinent question, I think. And I don't think we've had the right kind of quality of life scoring yet in MDS, to be honest. There's the qualms, it's pretty good, but it hasn't shown that big of effect in a lot of the trials. So and then higher risk MDS patients have, of course, different issues than lower risk in terms of quality of life. Even if independency from hospital care can be a very good point for both of the MDS patients. This is why in Florence we are now evaluating the possibilities to switch from sub-Q azacitidine to oral azacitidine in the patients with higher risk MDS who responded well to the sub-Q. So the ones who are in PR or CR, they can go on with the oral formulation. Of course, we have to, again, as I mentioned before, we have to control them and see how it goes, because we cannot just leave them alone at home and see.
And what about gastrointestinal problems? I mean, there used to be quite a lot. Is that still the case, or has formulation become better?
I think for oral, it's much bigger problem than for this.
Yes,
exactly. Yeah,
this can be an obstacle to the use of drugs. Still,
and then I think maybe. So I mean, nowadays, venetoclax is very hyped in AML, right? And we now have the MDS/AML subtype. So in my country, a lot of people think now that they should also the MDS patients should have venetoclax. What's your opinion on this?
You go for it.
I think that's a very difficult question, in the sense that we all put a lot of hope into the venetoclax HMA combination for MDS patients. I think probably if they have a high blast count and they're going towards AML, it will probably be the right therapy. As we talked before about high risk MDS without blasts, that's probably going to be too myelotoxic for these patients, I think. And we'll be very curious to see the results of the phase 3 Verona trial, because I think that the myelotoxicity may balance out the remission rates, so in the end, you might not see an effect in the overall survival because of the toxicity. And these older patients are very, very frail in their balance, and they need a lot of support for sepsis, and you have to really teach them well about what to look for, and if they're not feeling well, that they have to come in right away. And that can be a difficult issue. So I'm a big fan of venetoclax HMA for AML patients, even for younger patients. It's doing really well, I think. It might be a game changer even for 7+3, but for MDS, I'm not so sure.
Yeah, especially regarding the schedule of venetoclax and azacitidine or other HMAs, it's difficult to keep the entire schedule for all the cycles. So very often for patients with MDS, we have to stop giving venetoclax for, well, I don't speak about 21 days. That is extremely difficult, but even 14 sometimes is a challenge. So the bone marrow of MDS, it's somehow biologically different from AML, and we have to take this into account beyond and beside the fact that these patients are elderly and frail, as it was mentioned. So it's going to be an interesting tool. We have to select the patients that can
and we might need to do MRD monitoring to see if we could at some point stop the venetoclax and just continue with HMA maintenance, maybe in an oral setting, if they're MRD negative and have benefited from induction kind of type of venetoclax HMA.
So do you think that HMA will always be sort of the backbone in high-risk MDS, or are we moving away from this, or how do you see it?
It could be. By now, as you know, there have been several efforts to have a combination always with either decitabine, LAS, or azacitidine, and it has always been considered essential. Unfortunately, none of these new combination trials with pevonedistat or with also with the APR, the EPRA-NETRA-POP, very difficult to say. The TP53 reactivator. In phase 3, they never shown an efficacy higher than azacitidine alone. So we are stuck to what we were 15 and 20 years ago with azacitidine, but especially with the new immunomodulatory and agents, it could be that we will get rid of the hypomethylating agents and use only the novel agents, let's say.
There
are several.
Are you thinking of, in particular, magrolimab, or what are you thinking? When you say?
Yeah, magrolimab until now has been the most effective one, always in combination. Because this anti-CD47 antibody has given very good results, even in TP53 positive mutated MDS, more than 75% response, which is a very good overall, I mean, in all patients, which is a very good result. So how
long time does that last then? Do we know that? Is that lasting or?
Yeah, the duration of response seems to be quite good and stable. I think it's near 1 year, but we still have to wait again for the phase 3 results.
And it's not an easy drug to apply, right? I mean, for the way we have to give it and watch out for anemia and all these things, it's not gonna.
So what are the main side effects with that drug?
It's gonna make patient care that much easier, right?
Yeah, the most important and relevant management problem with magrolimab is the on-target hemolytic anemia. So the patient may have a very sudden and deep loss of hemoglobin, decrease in hemoglobin, even 3 grams. So you have to be ready to manage.
And it's not just at the beginning of treatment or something, it could come anytime or?
It is at the beginning of treatment, but can be very, very rapid. So again, we have to set up a strategy because we know that it may happen. So all the centers should be aware and prepared to have a very strict control of hemoglobin levels, even immediately after treatment. Do let's say an escalating dose and a priming with magrolimab, and also try to set up a very good collaboration with the blood centers for the immediate transfusions.
Yeah. One thing I forgot to ask you about, I'm still going back to venetoclax. When can we expect the result from the Verona trial? Do you know that?
cutoff has been, I mean, they're doing the data cutoff has been done, and they're cleaning their data. I don't know if we'll be able to see it for ASH, maybe at the end of the year, hopefully.
We hope so.
Well, otherwise, there's ESA next year, right? Yeah. No, that'd be interesting. Sure. Yeah.
Indeed.
Yeah. And of course, then it'll take a couple of years before it gets approved in Europe, right? So even if it gets approved, right? So,
but we could still use it. I mean, that's what we did with HMAs. We were using them long before they got approved in Europe.
Yeah. But you get reimbursed, don't you? Or how does it work in your country? Because I mean, here we have a social system for reimbursement, so it has to be, everything has to be approved for everyone. It's not like
if it's not approved, we have to ask the insurance company.
Yeah. In Italy, you can apply for a compassionate use or
we can do that too.
Or a personalized use. Of course, it's a lot of paperwork, and the ethics committee have to check very carefully, because we have the same system in Italy as in Denmark. Everything is public and everything has to be approved, of course. Which is good for patients in some sense, and for other sense, it can be a little bit slower for the approvals. For getting the drugs. Anyway.
Okay, so I was asking a little bit about transplantation. So which patients would you select for transplantation? Would you treat them up front with venetoclax, or how do you condition them?
Since it's the only curative option for MDS, we do try to offer it to patients that are eligible. I think the new IPSS-M, the molecular IPSS, has been pretty helpful in choosing patients for allogeneic transplant, at least at our center, I think so, because I've actually noticed that some of my low or intermediate risk patients become very high risk in the IPSS-M. If they have low blast counts or no blast counts. So I've been using that for transplant decisions. It used to be that we used the IPSS-R, and if they had poor risk molecular mutations, then we would upgrade them. And now we have a better tool. So especially
the same experience, actually. I
think the IPSS-M has been very helpful for the transplant eligible patients.
And can your institution find all the variants? We had some problem in, always getting the PLL into the, can you get, how does that work for you? No?
That's the problem. The availability of the entire set of mutation that is indicated in IPSS model, it's difficult to get in all centers. So it's a flexible system, so we may adapt even if we're missing data.
Exactly,
Yes, this is becoming a huge problem also for availability of NGS in general. So again, that's another objective and goal we have to render the treatment and management of MDS equitable and possible for all the centers and all the countries. It's a very powerful tool, IPSS-M, but it has to be adapted to the single possibilities of, again, countries and centers. It's very valuable.
I would fully agree on that. And I'm kind of struggling. I was wondering if you figure out how to do it.
No, it is a challenge, of course, everyday challenge, but we can implement it, but not all the centers can do it.
No, exactly.
And we need to have certified centers in all countries, possibly centralized. In Italy, we have, since a long time, the possibility to be reimbursed for all the NGS studies, but in some other countries, even countries, it's not possible. So it's something that we should face with EHA or with
that's a good point.
We
have the new topic in focus is precision medicine. So I think maybe there's actually an issue here we could work on.
It's a very important issue because we have to homogenize the possibility to be treated in all countries. So
we'll agree on that. So maybe we should work on that. Good.
Happy.
So then I was asking about your conditioning. I mean, how do you treat your patients before you transplant?
If at all possible, I would not pre-treat them. So if I have
what kind of blast counts do you accept before transplantation?
up to 10% usually.
Up to 10%, yeah.
And if I can do a rapid donor search and maybe have a haploidentical child to transplant or a sibling even, then we try to do a rapid upfront transplantation instead of pre-treating, because there is this concern if you pre-treat with HMA, you either induce myelosuppression, then you get maybe a fungus or some kind of infection in your lung, which would preclude doing the transplant. And also there is data saying that you actually create resistant leukemic stem cells that can, persist and then make a problem at relapse. So you might not be doing the patient a favor.
Because you sort of select for them, or
exactly. So we try to do upfront wherever possible. But if we can't, we do give the patient HMA for transplant. And if they have more than 10% blast, you could also think about doing the CPX 351 instead, so VIXIAS instead.
Yeah.
And we have absolutely the same strategy.
That's good to know.
Absolutely.
So you're doing well with the haplo, because I think we're not really using that a lot. So.
We use it a lot. The results are very good.
Yeah, a lot of haplo. Yeah.
Oh, interesting. We need to. Yeah. Good. So one thing we haven't talked so much is about what do we do when high risk MDS relapses?
That's a great challenge. If they do relapse like AML, so they progress more than relapsing, then we may try some more aggressive, if feasible, and if the patient is not too frail. Of course, there have been numerous publications indicating and data that chemo after HMA doesn't work. There have been several attempts to use novel drugs that unfortunately didn't show any advantage. I can just remember rigosertib and then
CD33 bites.
Exactly, the bites. And then we got other attempts that unfortunately didn't increase the response or the overall survival, I would say.
And would you think venetoclax would help in this situation?
It has been shown that has an activity in 40% of the patients who received HMA and relapsed, and then added to HMA could induce 40% response still, and an overall survival more than acceptable, given that it was 12 months instead of the 5
or whatever.
That we are used to. So this could be a good option. A single drug doesn't seem to work so well, but as an add-on, it could be really helpful.
And IDH inhibitors for those patients that have IDH 1 or 2.
So how many are there? How frequent is this?
Like
not many, right?
Total. Not very many.
No, but some patients may acquire it. And they can also acquire FLT3.
FLT3, yeah. Oh, yeah, and then you can use,
And then you can do gilteritinib, or you can do one of the specific inhibitors. I have patients, even older, very old patients, who progressed to AML. They were treated after relapse, after HMA with guadecytabine, obtain a sort of response, and then they had acquired IDH2, and now they have been maintained for a very long time with azacitidine. So this is
interesting, I think.
We should show it in a more consistent way and show that it's possible. Just sporadic, sporadic cases are interesting, but not really.
Yeah, but that you can't. Yeah, of course.
No, not making the path for a new. For new use.
But that might be at least one option for something that might work, right? I mean, we need some hopes there, I think, it's in relapse.
We try to put our patients on clinical trials in this situation if we have one on offer. We have the IRAK4 inhibitor trial, which it's a phase 1 and has a good signal for FLT3 and splicing mutations. So it could maybe be an option after HMA failure. Might become an interesting drug, hopefully. it has a little bit of a problem with rhabdomyolysis, so you have to be careful with that. But I think it's manageable. And for patients that relapse after allogeneic transplant, we try to do donor lymphocyte infusion plus HMA. Yeah. So DLI plus HMA, which can work quite well, actually.
Yeah. I think this is, we all do, don't we? Yeah.
Yes, hopefully.
Well,
yes. There are some new drugs coming with a new mechanism of action, very, very preliminary data. So I think that it is difficult to set up a study in refractory or relapsed HMA high-risk MDS patients, because, of course, it's a very treacherous field, and it's a ground that has to be, let's say, attacked with the care, because it is difficult to obtain a real response.
So also the companies are not so interested actually in doing because they might fail, right? They're likely to fail.
It could kill the drug, even if it's a good drug.
So that of course is a big risk to take. So I think, what do you think? I think we have been really well around the whole topic. I think, is there something else we should talk about that we haven't talked about?
No, there are other drugs that are immunomodulatory. The sabatolimab, the TIM3 drug that is targeting both the exhausted cells and some other immune macrophages, as well as possibly the leukemic cells. The data that we have seen until now are indicating more a prolongation of response than an increase on the rate of response. But again, this is just phase 2. We have to wait for the phase 3 trial and see how it goes. But there is much more attention to immunomodulation now, and targeting.
Even in high risk, because I know this is very hot and low risk, right? But you also see a lot of things going on in high risk now, right? It's very interesting.
We'll see.
Yeah.
Hopefully, but at least we know, well, actually, transplantation is immune therapy, right? So this is where we have seen a response.
Yeah, it's a little bit discouraging that we haven't in the myeloid field seen the same successes with immune therapy as we have in the lymphoma field. So we're really lagging.
So
I'm not sure.
Do you know of any results with bispecifics, and how well does that work? And what about CAR T? And the patients always ask, very good, because they read about this. So
we're a little bit backwards with respect to the lymphoid diseases.
They have a great time.
But I think because the diseases we're dealing with are hematopoietic stem cell diseases in the very high hierarchy of the hematopoiesis, it's just much harder to find an adequate target than it is for lymphoid diseases.
And actually what we experienced, was that after HMA, you actually get selection also of clones that also have mutations in the T cells. So maybe, maybe this can also affect, how immune therapy would work, I guess.
Absolutely.
Yeah. And the way to go is anyway to find a new mutation, acquired mutation, and possibly target them. Because it could be that you need a sequential therapy, that you need combined therapy with different inhibitors. This is what we have to find out. And the way, again, is to evaluate the molecular set of these patients.
Yeah. So you think we need also to do sort of MRD studies, or how do we, or at least repeated molecular studies, right?
I'm convinced that this is something very relevant for patients doing their disease history.
Yeah. So actually, we need to work on precision MDS a little bit.
Absolutely. Right? Yeah, we agree with that for sure.
Very good. So I think I would like to thank you very much for your time. It was fantastic. And you could find time in the middle of your busy meeting there. So it's really good.
Thank you very much.
It's a beautiful place.
Yeah,
it's nice actually very nice to do it together. I think we should do more of that.
Yeah, absolutely.
More fun.
Yeah. Thank you very much.
Thank you so much.
Thank you.
Thank you.